Good afternoon, everyone, and thanks for joining me for the latest breast cancer Q&A webinar. I'm Dennis Holmes. I'm a breast cancer surgeon and cancer researcher based in my primary office on the campus of Adventist Health Glendale in Glendale, California. This is the latest in a series of webinars. The next one is scheduled on November 20th, 2021. So I encourage you to mark your calendar if you would like to join us for another. I do plan to issue a new series of webinars for 2022. So you're welcome to join us for those as well. Before moving forward, I'd like to thank all of you for joining me today. I appreciate that we all could be doing other things, but there's some important topics that we can discuss. There's some important questions that some of you have, and of course, everyone can potentially benefit from hearing questions that are posed by others. So I appreciate your time today. I also want to give a special thanks to Sharon Merritt, who joined me for my last webinar. She solicited many questions from many of you, and it made it a very interesting experience. And so I hope to have her back again someday for a future webinar. Today's format is a 1.5 hour webinar in which I will take questions and provide answers. This will be live in that I'll receive your questions immediately and respond to them as quickly as I can, but it just in order to control the hour and to control the discussion a little bit better, I've decided that I would not be accepting questions verbally, but will ask for you to each submit your questions by chat. At the bottom of your Zoom window, there is an option to choose chat. If you choose that tab, a dialog box will open and you can type in your questions. I'll be monitoring the questions. I'll respond to as many as possible. I want to apologize in advance if I don't happen to answer the question that you feel is most important. You can certainly type it again if I miss it. I want to thank Allison, whom many of you have met. She'll be accompanying me virtually on this webinar, and she'll be able to screen the questions and perhaps tee some up that I happen to miss. But again, if I don't cover the question that you have asked, my apologies. I ask that you avoid requesting personal medical advice because I can't give proper advice without having a full analysis of your scenario, including review of your reports, images, pathology, and so forth. But if you pose a question that seems to be a little bit too personal, I will do my best to create a generic response to that so that it's information that addresses the question that you have, but also it presents the question in a way that's useful to a larger number of listeners. The webinar is sponsored by the Helen Ray Breast Cancer Foundation, and it is a 501c3 not-for-profit foundation that supports much of the research that I'm involved with. As I've mentioned before, the mission is to reduce the burden of care, and to do so by reducing the burden of surgery, breast cancer surgery, reducing the burden of breast cancer radiation, to reduce the side effects and burden of breast cancer surgery of the lymph nodes, and also to improve the overall breast surgery recovery experience. If you want to know more about the foundation, you can go to its website, Helen Ray Breast Cancer Foundation, and that's R-E-Y, not R-A-Y. You can read about what we do, and if you want to support us, there's a place for you to do so. And thanks again for those who have supported the foundation so far to continue the work that we have been doing. So now I have a reminder to unshare my screen. And now I'll begin to review the questions that have been submitted and provide responses. I'll preface it by saying that I have a lot of expertise in a very narrow area. So there may be topics that just aren't well equipped, that I'm not well equipped to address. Again, my apologies if I overlook them. But I'll start with the first question that I see. It's a question, no surprise, it's about cryoablation. The question is, please discuss where things are with getting breast cancer cryosurgery approved by the FDA. So as I understand it, the FDA has approved cryosurgery for treatment of malignant conditions and gynecological conditions, and that includes conditions of the breast. What the companies are trying to do is to get the FDA to provide a specific designation for breast cancer treatment. But as it stands now, the technology can be used for treatment of breast conditions, including malignancy. It's just not specifically spelled out as a treatment for that. The way that the FDA approves things is that it can approve something and demonstrate that it's safety. It's up to the clinicians to determine how to apply that. So you can take a device that is not necessarily FDA approved for breast, and in the proper informed consent setting, utilize that device to treatment for something that doesn't quite meet indication. However, there's a distinction between FDA approval and the ability to use the device and insurance coverage, because insurance coverage is based upon different principles. It's based upon the weight of the evidence supporting the efficacy of that. It's also based upon the support of national societies that have recognized that treatment as appropriate for that condition. And as of now, we haven't had the length of experience based on randomized trials with the follow-up from randomized trials or from non-randomized trials that have given the national societies sufficient confidence that they could say that breast cancer cryoablation is an acceptable alternative for the management, alternative to surgery for the management of breast cancer. And that's where we are. That's a process. That process, unfortunately, often lasts, 5, 10, or even more years before the community of breast cancer specialists embrace a new treatment as equivalent to the old treatment. And so that's where we're stuck at the moment. We have a technology that works for many cancers. We have sufficient FDA approval to use it in the breast for both benign and malignant conditions. We also have CPT codes, which are billing codes that the physicians can use to bill for the procedures. But unfortunately, we don't have society support. And we also don't have a value assigned to the billing codes so that when a physician bills for the procedure, they can expect to receive a reimbursement that's reliable. And so again, these are processes that are underway. I've gone through this process with intraoperative radiotherapy, which is an area of technology and that was applied to the treatment of breast cancers. I'm proud to have been one of the US pioneers of its application for treatment of breast cancers, and the studies of that have proven over time that it's equal to the traditional 6-week course of post-operative radiotherapy. But it took us 15 years, unfortunately, to get from the trials to having billing codes, to having insurance coverage, to have it now being considered an equal alternative to which people can access readily now. So it's frustrating that it takes so long, but we're heading in the right direction, but not nearly as fast as most of you would like me to get there. Now, one of the questions, a second question, is about cryoablation. I'm just going in the order that I see them at the moment. It had to do with the question of lobular cancers. Is cryoablation appropriate for lobular cancers? And it's a yes and no question, and yes and no answer. The yes part is that essentially cryoablation can kill anything that you can encompass with the ice ball. It works best when you have a tumor that you can see very well, that has fairly clear edges, so that you can decide how much beyond those clear edges you need to treat in order to get a clear margin, if you will. The challenge with lobular cancers is that they're the way that they grow in the breast makes it difficult for us to really see the edges very well. The cells tend not to aggregate or organize themselves compactly. They tend to spread out a little bit. And there also tend to be a few stragglers along the border. And so the concern with lobular cancers is that it's hard to assess the dimensions to reliably cryoablate it with clear margins. Now, there are some lobular cancers that are more compact, but there are many that aren't. So it really comes down to a case-by-case selection of patients to see if their mammogram and the ultrasound and the MRI all suggest that it's a fairly well-defined area, or if any of them suggest that it's not, that it's a more diffuse process. If it's a more diffuse process, it's a situation that's very difficult to manage with cryoablation. Often it's even difficult to manage them with lumpectomy. Many of them need mastectomy because of their extent. But if they're relatively small in the 1 to 2 size frame, then we can target what we see and then add a sufficiently wide margin, like treat extra volume, so that in case we're underestimated a little bit, at least we have a little bit of a safety margin by treating a larger volume of tissue. So the answer regarding lobular breast cancers is it's possible. It just depends upon the individual patient and how the lobular cancer manifests in her breast. So there's a question here about, you have done the trial for 8 years now, right? Actually, I'm not quite sure what trial you're referring to, so I'm going to ask for clarification on that question. There's a question about HER2 positive breast cancer. What are the current treatment options? And there's a second question about blood test post-treatment that the treatment was effective. Well, HER2 is one of the, and that's HER number 2, is one of the growth factor receptors that is present, that may be present, well, in high concentrations in certain breast cancers. HER2 is commonly present in most cells, but there is this phenomenon of amplification whereby instead of having, say, maybe 20,000 proteins on the surface of a normal breast cell or the average breast cancer cell, in patients with HER2 positive breast cancers, what we call HER2 positive breast cancers, they have a much greater number, like instead of 20,000, like 2 million. They have many more proteins, this particular protein, on their cancer cells. And the reason why that's important is that HER2/neu is a growth factor receptor which responds to certain agents, and when exposed to things that stimulate HER2, the cells tend to grow, the cells tend to divide, the cells tend to move. So HER2 positive breast cancers have a much higher rate of growth. They have a higher rate of spread, and that's because they just more excitable because of the abundance or excessive amount of HER2/neu protein. HER2/neu is one of the 3 major proteins we look at on breast cancer cells. There's estrogen receptor protein, there's progesterone receptor protein, and there's HER2 protein. And so as you know, the estrogen receptor and progesterone receptor proteins may be treated with medications that target estrogen, that aim to lower the amount of estrogen you make, or the tumor's exposure to estrogen. But then the other thing, HER2, is one that is targeted by different medications. Now, the most important advancement in the last 20 years for treatment of HER2 positive breast cancers is that there have been the development of antibodies, monoclonal antibodies, that you can administer a patient that specifically target the HER2 protein. So those antibodies essentially attack cells that have an excessive amount of HER2. And in that way, immunotherapy has really transformed the treatment of HER2 positive breast cancers. When I started training in 2002, HER2 positive breast cancers were one of the worst cancers that we encountered. When we saw it, it was a cause for great concern because we knew we had few options to effectively treat the cancers at the time. Now, when I see a patient with a HER2 positive breast cancer, I have a lot of reason for optimism because I know there's some really effective medications, even more than there were before, that can control these cancers very well, as long as the patient is willing to accept it. One of the challenges is that the HER2 medications work best when combined with chemotherapy. They don't work as well as a standalone therapy. So, getting the patient to embrace the chemotherapy as well as the HER2 is sometimes a challenge, but it is clearly the best way to treat a cancer that was once one of the worst behaving cancers. Based upon these drug developments, it's now one for which people can have great optimism about their prognosis because it can be so well controlled with drugs, which perform best when combined with chemotherapy. In terms of blood tests post-treatment that the treatment was effective, I am not familiar with any tests that can give you certitude that there's no residual cancer or there's no cancer recurrence. Of course, there's studies that look at circulating tumor cells, and certainly if you have a lower number of circulating tumor cells or no circulating tumor cells, it's a good indication that you've had a very good response, but it doesn't mean that there aren't any residual tumor cells that simply aren't circulating. There are also blood tests that we use to look for tumor markers, circulating tumor markers related to breast cancer. But many women with breast cancer don't have marker elevation. So if they don't have marker elevation at the beginning, when they're diagnosed with breast cancer, you can't always rely upon it to detect a recurrence. But certainly, if you have normal marker levels before you start treatment and then begin to detect a rise later, that might be an indication that you actually have developed a recurrence. And so some medical oncologists use those tests as a way to screen for recurrences. Not all do. The literature supporting that approach is a little bit mixed, but ultimately, the best measure of success is time. When people are diagnosed and treated, breast cancers tend to recur according to a pattern. The higher risk cancers occur quicker because they're faster growing. So HER2 positive breast cancers, if they recur, they're more likely to recur within the first 3 years of diagnosis because they do everything faster in a sense. Strongly estrogen receptor positive breast cancers recur slower because they generally do things slower. Their peak rate of recurrence might be in the 3 to 4 to 5 year time frame as opposed to earlier. And people with triple negative breast cancers, where they lack all three proteins, may recur within the first 1 to 2 to 3 years because they tend to do things the fastest. So that will at least give you some insight to look at where you are in your recovery from your treatment diagnosis, from your diagnosis and treatment of breast cancer, and also kind of how amount of confidence you may have in where you are, because the farther you are from your diagnosis, the more reason for optimism that there has not been a cancer recurrence. The next question I'm seeing has to do with cryo. Again, the question is, does cryo work for DCIS? The answer to the question is yes. I based that answer on the fact that when we conducted the initial studies of cryoablation of invasive breast cancer, half of the women with invasive breast cancer had coexisting ductal carcinoma in situ, because invasive cancer arises out of ductal carcinoma in situ in most cases, or DCIS in most cases. So, and when we treated them with cryoablation and then excised their tumors, the cryoablation worked just as well for the invasive cancer as it did for the DCIS, as long as the invasive cancer and the DCIS were within the targeted zone. So it works. The question is not so much if it can kill DCIS. The question is, how do you see well enough? How do you see DCIS well enough to target it accurately? And that's a question that we are sort of addressing in the trial, which many of you may have heard about, the cryoablation for DCIS study that was recently opened. In fact, we're treating our first two patients this upcoming week, next week. That was funded through an effort supported by many of you through a matching fund effort with doTERRA. The idea is that we'll take patients that have small areas of DCIS, ideally DCIS measuring 2 centimeters or smaller, as assessed by imaging, mammogram, ultrasound, maybe MRI. Since DCIS is hard to see by ultrasound, it's necessary to create an ultrasound visible target so that we can perform ultrasound guided cryoablation of the site. To accomplish that, we will have patients undergo insertion of an ultrasound visible marker next to their existing marker. Most of them will have a marker already, or at the site of the residual calcifications. And then after having that ultrasound visible marker placed, we would take the patient to cryoablation with ultrasound used to find the site where the marker is present and target that site for ablation. And so essentially it's the same approach that we use for invasive breast cancer. It's just that we need to have a marker placed so that we can visualize the site of DCIS better, so we can target it accurately with cryoablation. In the study that is being conducted, in order to confirm that the treatment is effective, we're recommending, the study requires that women undergo a core biopsy of the cryoablation site 6 months post cryoablation to document that the area that was ablated is indeed dead. And ultimately, we will report out these results when the study is completed. But I think we have 3 patients in the queue now for cryoablation in the study, with 2 to come next week. And there's been a lot of interest in it, so do spread the word about it. There's a question about calcium and calcifications. As you know, in breast cancer screening, particularly mammograms, it's common to find calcifications in the breast. And some people have expressed concern that dietary calcium was really the problem, that perhaps they should reduce their calcium in their diet because that will help to prevent them from developing breast cancer calcifications. And it's not as simple as that, and that's also not really the right solution to the problem. Breast cancer calcifications occur as a side effect of a process in which some of the cells die. And cell death is kind of a normal part of growth. The breast ducts develop when the breasts are developing, and eventually after menopause, and even before menopause, some of those breast ducts involute. They die, some of them become cystic, so that's why some people have breast cysts. And some of the cells become petrified. You know, the dead cells tend to become petrified if they're not digested. And one of the ways that they petrify is that your body kind of deposits calcium with them. So there's basically kind of a dead cluster of cells that are now calcified or fossilized that remain in the breast. And these fossils of dead cells are detectable on the mammogram. And that's why some people are found have, in fact, most women over their lifetime will develop some calcifications as a fossilized manifestation of dead cells that were once, you know, living, functioning breast cells. Now, you know, in most cases, the calcifications are completely irrelevant. They're normal. They require no commentary. They're just normal background features that show up on a mammogram. But sometimes the process of cell death and fossilization or calcification can happen with the malignancy, meaning that as breast cancers form, some of the cells typically die. The reaction, the healing reaction to that area of cell death is often the formation of calcium deposits. And those calcium deposits can provide a clue that a malignant process is underway. The distinction is in the pattern. So when calcifications are clustered in a certain way, or they're angulated in a certain way, or they're branching in a certain way, like they're maybe filling the duct, then when they form a certain pattern, we might consider that pattern suspicious enough to be concerned about cancer. And when we are, then we recommend a biopsy of the site. On the other hand, and more commonly, we have a pattern of calcifications that are benign. They're scattered. There's one here, there's one there. They're not particularly concerning, then don't seem to be associated with one another. We consider that a condition for which simple follow-up is needed. No biopsy is needed. But of course, there's patients that are fall in the middle, where they have calcifications that are new, and the radiologist is not quite confident if they're in the benign category or malignant category. We'll often recommend biopsies of those calcifications. Well, either follow up 6 months to recheck them, or a biopsy just to resolve the uncertainty. But in this way, and this is the take-home message, calcifications in the breast can be your friend, because they can enable the detection of a breast cancer at a very early stage, when it's only detectable because the calcifications have formed. Before mass forms, you can often find breast cancers if they're calcium developed, if they have calcium associated with them. So I think that, you shouldn't try to eliminate calcium to avoid breast calcifications. It won't work, number one, but it also might accomplish a goal that you don't want to achieve, which is to make it harder to detect breast cancer. I would conclude that report discussion by making the point that the ductal carcinoma in situ is the earliest form of detectable breast cancer. It is most reliably detected when it has calcifications associated with it. And with the use of mammograms, which is something that is really tuned well to finding calcifications, we're able to find breast cancer at its earliest possible stage, that is, in the form of DCIS, much more reliably than we can with ultrasound. So I know there are many of listeners who are not crazy about the idea of having mammograms, or maybe concerned if the mammogram is more risk than benefit. But I would encourage you to at least think more openly about it and recognize that the mammogram is the singular test that is best suited for detecting breast cancer when it presents in its earliest stage as DCIS with calcifications. So if you don't want to do mammograms, I respect your choice, but you're limiting the potential to find breast cancer at its earliest age. And you should do this kind of with that understanding. There is a question about, she said they've gone to clinicaltrials.gov, which is where many clinical trials are listed, and said that there have been clinical trials on cryoablation that were started years ago, and I guess she's wondering what's taking them so long. And I agree. There were many that were started many years ago, and some that I participated in, including the was what we call the ICASOC Z1072 study, which was launched in 2009 and reported out its results in 2016. The problem with the studies as they currently exist is that they are non-randomized trials. So often when we are trying to determine if a new treatment can work for a problem, we'll do a pilot study, which might be a study of just 20 patients, for example, and then maybe a phase 1, a phase 2 study, which will treat a larger number of women, maybe up to 100, maybe 200, like the FROST trial or the ICE3 trial. But those trials tend to be non-randomized, which means that we're just taking kind of an ideal group and offering them a treatment to see if the treatment works, to learn from that, and ultimately to utilize that information to find the most appropriate application. And that works to help us move forward. And in fact, that's what most of the trials, and that's what all of the trials that you see on clinicaltrials.gov have aimed to accomplish, to understand the application of cryoablation in treatment of breast cancer, so that we can learn from that and apply it in a way that clearly allows us to determine for whom it works best and if it's as good as the alternative. And so what we have not done, what is long overdue, and it's really just a financial question, is can we do the thing that is needed for cryoablation, which is to do a randomized controlled trial. The gold standard for breast cancer treatments is randomized controlled trials. meaning you take a group of patients that have the treatment, you take a group of patients that don't have the treatment, that have been randomly assigned to receive the treatment or not. So the goal is to eliminate patient bias, to eliminate physician bias, and to make the treatment selection a randomly decided process. And then over time to see how the two groups do. It's certainly an inefficient process, but since women's lives are on the line, we want to make sure that the treatments that we're recommending are based upon kind of an honest assessment of the outcome, not doctors and patients picking the best ones and making and sort of tweaking the data so that it fits. This is really the most honest way of doing it. And so the trials for cryoablation so far have not been randomized, but I am pleased to be a part of an effort to conduct a randomized controlled trial. It's still in the design phase. It's to be funded by a company that has the resources to sponsor the trial. That's been the issue, is whether you put together the money to do a large 2,000 patient, which is the size you need, randomized controlled trial to show that cryoablation for small tumors is equal to lumpectomy, or at least close enough to lumpectomy for small tumors to be considered an acceptable alternative. That's where we are. We've done enough phase 1 trials, I think, for cryoablation of small tumors. We need to do a randomized controlled trial. And it's really the randomized controlled trials that the breast cancer societies use to make guideline recommendations. When those trials are initiated, and certainly when they're completed, it's much more likely you'll see widespread adoption of cryoablation as an alternative to lumpectomy that's covered by health plans uniformly. The question is, the next question is, what percent of DCIS becomes cancer? It's estimated that about 25% to 50% of DCIS will become cancer over a woman's lifetime. Now, that's a kind of a, it's a difficult number to process, but basically the way that they came up with that is that they did a study of women that had a diagnosis of DCIS that was perhaps misclassified, as that was thought to be benign. But then when the researchers looked back at those slides, they realized that those patients actually did have DCIS. And then when they looked at the outcome of those women, they realized that only a portion of them, not all of them, progressed to invasive cancer. Only about 25 to 40% of them actually progressed to invasive cancer. So based upon that, this historical study with 25 years of follow-up estimates that only about 25 to 40% of breast cancers will progress, and those are crude estimates, will progress to invasive cancer over the lifetime. It's not always so clear to understand which one will and which one won't. Now, we do now have genomic tests which do help to sort of assess the 10-year risk of progression from DCIS to invasive breast cancer. But obviously most women want to plan for more than 10 years. So it's hard to say exactly so, but the reason that we treat DCIS as breast cancer or as invasive breast cancer is that we're trying to remove it before it has a chance to progress. So for someone who's younger in age, who has a more a high-grade DCIS or an estrogen receptor negative DCIS, or then those patients are more likely to progress in general. Patients that are older, that have low-grade DCIS, that have strongly estrogen receptor positive, progesterone receptor positive DCIS are generally less likely to progress. So, there is room for judgment. There is room for patients to decide what treatment options fit them best. Surgical treatment versus watchful waiting, surgical treatment versus medication, like anti-estrogen medication. You have more options with DCIS, and now we're introducing a new tool, cryoablation, as an alternative to surgery, as a definitive way to manage it with, and also preventing it from progressing to invasive cancer, because we actually do deal with it by killing it, as opposed to simply monitoring it to see if it will grow and develop into DCIS, develop into invasive cancer in the future. So there's now scientific evidence that biopsies can cause seed tracking, which results in later cancer metastasis. And can I address this? That's the question. So I think it's an interesting and challenging problem that we have in dealing with balancing the need to diagnose a breast cancer as early as possible and get a patient onto proper treatment, and avoiding a biopsy for fear that the biopsy might be the source of spread. I think that although there are data demonstrating that biopsies can cause seed tracking, there is not sufficient data to show that that actually has a difference in outcome in terms of recurrence and survival. And that's part of the reason, and that's partly due to the fact that the story doesn't end with a biopsy, that patients hopefully will go on to receive the appropriate surgical treatment, they'll receive the appropriate medical treatment, they'll also receive the appropriate radiotherapy for that diagnosis, which together will control not only the initial risk of recurrence, but also the potential recurrence along the track. Now, even with mastectomy, someone can have a recurrence. So it doesn't mean that simply leaving the track, that avoiding the track will avoid the potential for recurrence. There's always a potential for recurrence, but the potential for recurrence is considerably less when you add adjuvant therapy, adjuvant meaning radiotherapy, or drug therapy to the mix. The alternative, which I sometimes see people do, is to avoid a biopsy altogether. But in the process of avoiding a biopsy, they allow the tumor to grow because they go on for a longer period of time without a diagnosis and without an appropriate treatment. And with that, there is a greater potential for spread. Now, even when the tumor has not been biopsied, there is clear evidence that their tumor cells migrate from the tumor site. We can measure it by measuring circulating tumor cells, that even before a person is ever diagnosed with a needle biopsy, that you can detect cancer cells in the blood. So it's not like not biopsying it will avoid that. It's also important to know that just because there's circulating tumor cells in the blood, that does not mean that those cells are viable, that they have the ability to take up root and grow in a different site. But the take-home message is, I think, performing a needle biopsy to diagnose a breast cancer has a lot more value, a lot more positives than it has negatives, even if tumor tract seeding is a possibility. I think there are precautions that providers can take to minimize that, because we don't want to throw the baby out with the bathwater. We want to be able to both perform biopsies and also minimize the risk of spread. So many of us, when we perform biopsies, we use something called an introducer, which is basically a larger bore needle that's inserted into the breast, up to but not within the tumor, so that when we take samples, the biopsy needle rather, can be inserted through this exterior needle. So the introducer is the outer needle, the needle biopsy is introduced through the center of the introducer, and that allows us to take multiple samples without dragging the tumor sample repeatedly through the breast tissue tract towards the skin. And so use of an introducer does help to minimize the tracking. We also use local anesthetic solutions that contain epinephrine. Epinephrine tends to cause the blood vessels to constrict. So when that's injected around the biopsy site, it tends to keep things in place, makes it less likely for it to sort of escape. That's theoretical, but it still is, it's a rational step to take in order to minimize the potential for spread. There's also sort of a little bit of a a cryoablation consideration as well. I see patients that come for a biopsy and cryoablation because although they're open to having a biopsy, they want to sort of minimize the potential for spread. And so sometimes we pair that with the cryoablation procedure, which is to, perform the cryoablation immediately after the biopsies so that we can get a tissue sample, most importantly, but we can also kill the area immediately after so that after the biopsy, there's no potential for spread of the tumor because, of course, it's been ablated immediately after taking the sample. There's a question here, how does the medical community differentiate between low-grade DCIS, intermediate DCIS, high-grade DCIS, and why DCIS has various grades? Well, it's a challenging question, but it's an important question in the big picture, in the scheme of things. A lot of this comes down to judgment that, as with most biological conditions, DCIS is on the spectrum. Some are clearly low grade, meaning they have non-aggressive characteristics. Some are clearly high grade, meaning they have quite high aggressive characteristics. Some have fairly average characteristics, and some are in the middle. And so, in addition, sometimes you have an area of disease that's heterogeneous. There are high-grade portions, there are low-grade portions. It's a mixture. And so the pathologists have to make a judgment. They make the best judgment they can. They kind of give kind of a global assessment of the findings. If it's mixed, there's some high and low grade, they might say it's intermediate to high grade. If it's mostly low and intermediate, they might say it's intermediate to low grade. But one pathologist might grade it one way, another pathologist might grade it slightly another. So it's not an exact science, but that's essentially what they try to do, is kind of give you a gestalt of the overall pattern of DCIS and its aggressiveness based upon a survey of the tissue. Now, you must also recognize that the survey is often based only on a needle biopsy sample. So if you have a 2-centimeter area of calcifications and they've taken a needle biopsy sample, that needle biopsy sample might only represent 5% of the total volume of the DCIS. So even if you're perfectly accurate in assessing what's in the core, it doesn't necessarily reflect that all the parts that remain are the same. And so it just might not be possible to know. Certainly when you have if you have lumpectomy, it can be taken out and it all can be evaluated so that an opinion can be rendered regarding the whole area. However, if you opt for cryoablation, we can only make a judgment on the initial biopsy sample. We can't make a judgment on the part that's ablated because hopefully, if ablation was successful, that the residual DCIS will never be seen again, and therefore that information is not knowable. But the answer to the question is, pathologists will use their best judgment based upon what they see, and there's some variation to that, largely due to the fact that the tumor has variations in terms of the grade. And some parts have high grade, some parts have low grade, some parts may be mixed, and everyone's different. So there's a question about Paget's disease. Paget's disease, as some of you know, is a manifestation of breast cancer in the skin of the areola and nipple. Most often it starts in the nipple and extends to the areola if it continues to grow. Sometimes it can start in the areola without involving the nipple, but it is the equivalent of stage 0 breast cancer that has involved this skin of the nipple and or areola. And in general, it is a problem that is managed surgically. So if someone, say, has a lumpectomy and they have Paget's disease of the nipple and areola, then removal of the nipple and areola, or whichever part is affected, is a routine part of that. Or if they have a significant volume of disease underneath the skin, like large area of DCIS that requires a mastectomy, then a nipple and areola would be removed with the mastectomy. That's the routine management of Paget's disease. There are some non-operative approaches to it. Radiation has been known to work against it in some cases. There's photodynamic therapy, which has also been studied in some small studies looking at that as a possible alternative. But for the most part, the only sure way to do so is to manage it surgically. And so that's generally what I recommend for women presenting with Paget's disease. So I think I'll leave that question as it is. Let me scroll back. I think I might have missed some along the way before I pick up on the latest ones. Thank you. I think I'm doing okay. So how do we know if we have multifocal DCIS, and is cryoablation ever appropriate for those of us with multifocal DCIS? Well, multifocal DCIS means multiple areas of DCIS in the same quadrant of the breast. That's the basic definition, meaning that you might have 2 or 3 different areas of DCIS in the same quadrant of the breast. The first question that I would ask for someone presenting with multifocal DCIS is, how thorough was the workup? Because in many cases, it's not actually 2 separate foci. They're actually joined. It's just a matter of whether or not you can see the connections between the 2. So if they're actually joined, we would consider that a single focus as opposed to 2 separate foci. So of course, with any DCIS evaluation, I think mammograms are crucial because mammograms have the ability to see DCIS. And in fact, the mammograms might see a cluster of calcifications here, but it might not see the parts that are not calcified that connect the 2. And in that way, MRI has some additional advantages because it can sometimes see parts of the cancer that hasn't yet formed a mass, that hasn't yet calcified, but is detectable because the blood flow is enhanced around this growing malignancy. So the first question is the extent. How well do we understand the problem? And then once we know the problem, then the next question is, well, what area is taken up by that problem? Is it a multifocal area that spans 2 centimeters, or is it a multifocal area that spans 10 centimeters? It really comes down to the amount of tissue involved. Certainly for small areas of DCIS, even if they're multifocal, though the traditional treatment would be to treat it with surgery, you can also treat them with cryoablation. Again, it requires placement of the marker so that you can target it accurately. We will place a marker within each focus, but you also need to know, have the best assessment of, whether or not it extends beyond those markers or beyond the calcifications in one direction or another, so that the area that is treated accounts for that. And that will be true for surgery as well as for cryoablation. So I have treated patients with areas of DCIS spanning several centimeters. The way that was achieved is that we had to utilize multiple ablation treatments to cover the volume so that we could treat the DCIS as well as the surrounding margins. It would be helpful to know in this, in answering the question, that the area of each ablation treatment only covers about a 4 by 3 by 3 centimeter area. So if you look at this, I know the scale doesn't work, but if you look at this tool that I have, this is, you can look at the size of my finger here. And this circle here is 4 by 3. And so if you think the other direction, 3, if you think of it as like an oval, a 4 by 3 by 3 area is what can be accomplished with the typical ablation. The technology that has been developed for treatment of breast tumors was really designed to treat tumors the size of a dime, a penny, or a nickel. And so any of those would fit fairly easily within this zone and leave enough tissue around for you to have a clear margin. That's the limitation. But if we have an area of disease that's larger than that, it is possible to use several partially overlapping ovals, one overlapping the next, so that with a series of them, we could cover an area the size of a $50 or silver dollar or larger, but that will require, again, multiple overlapping ablations to cover the detectable disease as well as the surrounding margin, so that we can achieve a clear margin around that. So it comes down to understanding the extent of the workup. It comes down to reviewing the workup to figure out the extent of disease. Is it linear? Is it irregular? Are there extensions that need to be accounted for? Basically, the 3 dimensions of the area of disease or DCIS needs to be assessed. And then based upon that, I can make a judgment about the cryoablation approach. I can say that I've treated some fairly large ones. It would not have been my first, second, or third choice for those patients, but it was the only choice that they were willing to accept. And so it was certainly better than allowing it to continue to grow into invasive cancer. When we do have large areas of DCIS, I usually recommend additional biopsies of the area at the time of cryoablation, because we want to make sure that there aren't hidden areas of invasive cancer in the DCIS. And in fact, for a number of cases have revealed DCIS when those biopsies were performed. We still proceeded with the treatment, but at least we were not misled by assuming that the patient only had a diagnosis of DCIS. When we found the invasive cancer areas within the larger field of DCIS, we were able to recommend appropriate management of the patient. So I think I've addressed that question sufficiently, and if I haven't, you can certainly add an additional question for further clarification. So there's a question, so apparently someone has, actually I'll come to that question next. I'll answer this question. Why is MRI used as a diagnostic tool for breast versus PET scan or a CT scan? Well, every test has its strengths and every test has its weaknesses. And we do our best to, make them work, to extract from them the information that they can provide. So MRI, and specifically MRI with IV contrast, has been developed as a tool for screening and evaluating breast conditions. It is one that works well because it specifically looks at blood flow, areas where the blood flow is enhanced, abnormally enhanced. That's the term we use, enhancement. And it is one that has resolution down to as small as 2 millimeters, where it can see a cluster of new blood vessels developing that's no more than 2 millimeters in diameter. And for that reason, it's very sensitive, and it's really helpful in screening breasts, especially when you're looking at small areas of invasive cancer, or you're considering small areas of DCIS, which often are more like strands of fibers as opposed to a mass forming condition. So MRI is well suited for that. And for that reason, it is a standard tool. It also works very well for dense breasts, and it does not use radiation. So another upside. Now, the problem with the PET scan and CT scan is that although they're great for screening the whole body, that they don't really have the resolution down to 2 to 3 millimeters to find small areas of disease in the breast. The PET scan is the worst in that category because it really doesn't see things very well under 5 millimeters. The PET scan is better. It can see things down to 5 millimeters, but the PET scan is a functional study. It's basically a combination of the CAT scan plus a radioactive substance that's injected, that's attached to glucose. The cells that take up the glucose and that take up the radioactive glucose are detectable on the PET scan, but as a functional test, if the cells aren't very active, they don't take up much of the glucose. Not all breast cancers are very active. So an active breast cancer that is low grade, that's slow growing, is less detectable by PET scan, it might be completely missed. Or if it's just small, 4 millimeters, 5 millimeters, it might be below threshold. So we don't use, take home message, we don't use the PET scan or CAT scan for screening of the breast. There are clearly better tools for that. Those tools are best used for screening much larger volume of areas, like screening of the whole chest, or screening of the whole abdomen, or screening of the whole body, but not as a tool for breast cancer screening. In addition, both the PET scan and the CT scan utilize radiation, and they use higher doses of radiation. MRI uses no radiation. So if you're concerned about the radiation from the mammogram, you should definitely be concerned about radiation from the PET scan or from the CT scan. There is a technology called PET CT for the breast. It's a specific adaptation of PET scans that are used for screening the breast. They still rely upon radiation, and they're still not as good as MRI in my judgment. So I think MRI, in addition to mammography and ultrasound, remain the preeminent studies, the best studies for screening breast conditions. The other studies are best suited for screening the whole body. There's a question about side effects, long-term side effects from cryoablation. There's a very slight skin redness and tightness. Is that normal 1.5 years after cryoablation and radiation completeness? So this individual apparently had cryoablation, and she also had radiation, and both can produce long-term changes. I always tell people that, you know, even though we can successfully kill a cancer with cryoablation, we do produce a mass that will take some time to go away. The rate of resolution of the mass will depend upon a number of factors. It will depend upon the amount of volume you ablate. The more volume you ablate, the longer it takes for it to disappear. It also depends upon patient age. In my judgment, dense breasts, which are generally present in younger women, tend to heal faster than fatty breasts, which are more common in older women. There's also an issue of breast size. If it's a small breast, the lump will be more obvious. It'll take longer to go away. If the tumor is closer to the skin, the lump will be more obvious, so it'll take longer for it to disappear as well. And sometimes there are areas of fat necrosis that can form in either dense breast or fatty breast, but there are areas of fat necrosis that may form. And fat necrosis may sometimes feel quite hard, even though it's just fat, or sometimes even just liquefied fat. Sometimes it calcifies as well. And so there can be reasons for you having something that lasts even longer, that's firm. But I generally recommend needle biopsies of the cryoablation site 6 months post cryoablation. So with a benign result, which we almost always get, I am very confident that, you know, we can watch and wait whatever time is needed for the lump to resolve. And of course, with follow-up imaging, mammograms, ultrasound, and MRI, we can detect whether or not, you know, there's a recurrence that happens along the way. So that's sort of the mass-like effect. Now, as the mass is absorbing, it can have local changes because the area is still healing. So there can be firmness there, there can be stiffness there can be tenderness there as well. There might be some retraction, although there generally isn't skin retraction with cryoablation. If there was not retraction before, there's less likely to be, it's unlikely that there will be some in the future, but I suppose that's possible. And if the cryoablation was close to the skin and there was a skin injury, even just kind of a, you know, first degree or second degree, there can be some skin redness that persists. Now, the persistence is more likely to be on the order of weeks to months as opposed to years. If you still have redness in the area, I think it's more likely to be due to the radiotherapy, not the cryoablation. Worst case scenario, though, is sometimes residual skin redness can be a manifestation of residual cancer or cancer recurrence. So it's important to have the area seen by a provider who can give you some reassurance that the findings that are observed are post-treatment changes. If there's any uncertainty about that, a skin punch biopsy would be helpful. A small sample of the skin full thickness can be done to see if it's malignancy or if it's like radiation dermatitis, which is a common cause of erythema after radiation. So why is it mostly radiologists that do cryoablation and not surgeons? I asked that question as well. And to be frank, I am okay with it, but I have concerns about it. I think that the main reason that most radiologists tend to do it, as opposed to surgeons, is that radiologists, almost all radiologists, or at least radiologists, are more likely to have the skills to perform image-guided procedures. They routinely perform core biopsies, and so since cryoablation is really kind of a very an experience that sort of mirrors the process of performing core biopsies, it is automatically in the skill set of a radiologist. And so that's why, from a technical perspective, there are many more radiologists that either are doing or can do cryoablation right off the bat. They're used to looking at ultrasound, they have the equipment in their offices, and they're used to performing needle-guided procedures. So that's where we are. Now, the concern is that, in the management of breast conditions, radiologists are generally technicians, meaning they just do the procedure and they hand the patient over for someone else to provide the global care. And as you know, breast cancer management requires global care. It's not just a matter of performing a biopsy or freezing a tumor. It isn't even just a matter of performing surgery. It has to be comprehensive. It needs to be multidisciplinary. There needs to be follow-up. That includes exams and making sure that people who are agreed to take medication are compliant, and so forth. And so, although there may be radiologists that do participate in the continuum of care by collaborating with the other providers that would be involved in the patient's care, my concern is that most radiologists function more as a technician, meaning that they do the procedure, but they do not take a responsibility to provide for the global care of the patient's cancer. So I'm not opposed to radiologists doing it, but when they do, I think they have to do it as part of a coordinated multidisciplinary team if they want to maintain the current standard of care, which is to provide comprehensive multidisciplinary care to breast cancer patients. That's where the best outcomes are likely to be achieved. I have been doing cryoablation now for about 18 years, and I've been involved with teaching both trainees and physicians to do, surgeons to do so. So it's my hope that it will become a tool that will be used much more readily in the future. Certainly when we work out the billing collections issues, surgeons will embrace it more and more. But I think that answers the question. So should radiologists do it? They can, but they should do it in a responsible way. And that means that they need to treat the whole patient, meaning that they need to do more than just a procedure, but they need to be willing to communicate with the medical oncologists about the treatment. They need to provide follow-up. They need to be involved in performing physical examinations and symptom management. They need to be involved in making recommendations for future imaging and following up on the imaging, which they certainly are able to do. And if a patient needs to, have an indication for radiation, that they need to be willing to communicate with the radiation oncologist. Really, they need to be a member of the team, not simply someone who's performing a technical procedure who then goes off and washes his or her hands of their involvement in the process. Why do radiologists have such a difficult time differentiating between cryoablation nodule and breast cancer tumor after the patient has had cryoablation? Well, the simplest answer to the question is that very few of them have experience reading post-cryoablation imaging studies. So and that's true for all of us. I mean, it's a learning curve. Those that have had experience have more confidence in doing so, but it's probably less than 1%, probably far less than 1% of radiologists have seen a patient treated, have seen a post-cryoablation mammogram or post-cryoablation ultrasound or MRI. So they just don't know what they're looking at. You know, those of us that have more experience do have, can read these studies with greater confidence. And I have a fair amount of experience, but when I have patients that want to have their studies reviewed, I will look at them, but I'll say, I will refer you to a radiologist with whom I've been working for this one in particular, for the last 10 years, who has seen many patients that have been treated with cryoablation, seen their mammograms, ultrasounds, and has developed sufficient experience that she can confidently interpret the results and reassure patients that the results are benign, or make up an appropriate recommendation for a biopsy if she sees fit. So it's really just a matter of time. It's a matter of learning curve. Now, I do encourage people, however, to kind of challenge their radiologists and to have their imaging studies performed at home. They will tell you that they don't know what they're looking at. They may sort of hit him and haw. You do have the option of having the studies read by an independent radiologist, the one that I just mentioned, but the experience nationally won't grow unless we give radiologists the opportunity to learn. And so, you know, it is, you know, just the nature of where we are now with this new technology. But in 5 years and 10 years, more and more will feel comfortable reading it. We have been collecting the CDs of patients that have been treated with cryoablation by us, so that we can develop kind of an album of the typical things you see at 6 months versus 12 months versus 18 months versus 24 months and so forth, and with the goal to ultimately publishing that information so that radiologists can at least have a resource that they can look to, a paper that can say, oh, this is what I should expect to see at 6 months. This is what I should expect to see at 2 years or 4 years, so that they at least have some parameters in order to use to interpret what they see. But it's just a matter of the learning curve now. They will get there eventually. There's a question, what is postpartum breast cancer? Well, the term postpartum means that it happens after a pregnancy, but the more precise term, or the more appropriate term, is pregnancy-associated breast cancer, which includes breast cancers diagnosed during pregnancy and within 1 year of delivery. We consider them all pregnancy-associated breast cancers. And so a postpartum breast cancer is one that was diagnosed, at least the way that it's been, I assume that this is experienced, that the patient delivered her baby and then within a year of that was diagnosed with breast cancer. That is a pregnancy-associated breast cancer, technically a postpartum breast cancer, but pregnancy-associated breast cancers also include those that are diagnosed while the woman is still pregnant. You know, breast cancer, pregnancy long-term is considered to be something that reduces the risk of breast cancer. But during the pregnancy itself, because of the high levels of estrogen, it can be a fuel to drive the development of a breast cancer that is already in development. So the risk can go up slightly higher during and immediately around pregnancy. But generally speaking, the more pregnancy someone has had over her lifetime, the less and the longer she is breastfed, statistically speaking, the less likely she is to develop breast cancer. And so, since I was just asked for the definition, I won't get into the treatment of pregnancy-associated breast cancer. But if there are questions about that, if there's sufficient time, I'll do my best to respond. So, is 3D mammography better for detecting breast cancer than a regular mammogram? And the answer is generally yes. The data are clear for women with dense breasts. So 3D mammography is basically a mammogram that takes not just, say, a left view and a right view of the breast, or two views of a breast, but one that takes multiple views. It's almost, if you think like a CAT scan, where it takes multiple slices through the breast to look at the breast, not just in two views opposed, but kind of like a loaf of bread where you can look at many different slices of the breast to assess whether or not there's something inside. I guess 2D is more like having the first slice and the last slice and making a judgment, and 3D is like having all of the slices to make a judgment. That analogy might not work completely, but the point is that 3D works better because it can see more layers and it eliminates some of the overlap that sometimes can produce a false impression of the imaging findings for mammography. Now, I said it depends on the age. For women with dense breasts, the evidence is clear that 3D mammography is best. So generally, postmenopausal women with fatty breasts or non-dense breasts don't need 3D as much as women that are younger and have dense breasts. If you have a choice, however, I would always choose 3D because more likely, I mean, it's for the whole population, it's a better study than 2D. But if you're older, if you have fatty breasts, if you have non-dense breasts, and if you only have access to 2D, I think 2D will work perfectly fine for you. Secondly, or the last point I want to make is just because you have a 3D mammogram doesn't mean that it will always find the breast cancer. Breast cancers can still be missed in 3D mammograms. So if your breasts are dense, or if you have a breast symptom like a lump or focal area of pain, and your mammogram is normal, you should still insist on an ultrasound because 3D mammograms can still miss things. So if you have dense breasts and you're getting 3D mammograms, you should still ask for routine ultrasounds along with that. Or if you have non-dense breasts and have a 3D mammogram and you have a breast lump, for example, you should still ask for an ultrasound to evaluate that lump because in a non-dense breast, it's still possible for a test to fail. And you wouldn't want that to happen if you could avoid it for you. So 3D mammograms are great. They're better than 2D, but they don't solve all problems. So ultrasound still has a role, even for patients with 3D mammograms. Is 3D mammography a higher dose of radiation? Slightly higher. But I think in the scheme of things, when you consider, the fact that they often have to take repeated views because they can't see an area well enough, I think when you average the amount of radiation that someone will get from 3D versus 2D, I think the difference is insignificant. It's higher with 3D, but the difference is insignificant, and certainly weighed against having something that will diagnose a breast cancer much earlier. I think it makes more sense to accept the slightly higher risk of radiation exposure for a much higher ability to detect the cancer earlier. Okay, I'm scrolling through the questions now. So I have questions about inflammatory breast cancer. So inflammatory breast cancer is a breast cancer that appears where the breast appears to be inflamed, meaning that the breast is swollen and it's red in color. And it generally involves a large portion of the breast, not just a small area of redness, but maybe a quarter or a third or more of the breast. And the swelling tends to leave the skin thickened and have sort of the appearance of an orange where there are little pits along where the skin appendages like hair follicles and sweat glands are more prominent. They form little pits when the breast is swollen. It is considered to be a stage 3 breast cancer. It's a specific type that has a specific diagnosis and a specific way of managing it. It comes about because as the cancer develops in the breast, it moves fairly early into the lymphatic system of the breast. So it blocks up the plumbing of the breast, blocks up the lymph nodes because They usually have lymph node involvement, but also blocks the little lymphatic vessels coming from the tumor to the lymph nodes. And it creates a plumbing problem that causes the breast to swell. And it tends to come on somewhat dramatically, meaning that your breast is fine today and 2 weeks from now it's red and swollen. It doesn't come up over 3 to 6 months. It comes up usually within a few weeks, it develops. It's not that the cancer developed that quickly, it's just that like happens at home. Sometimes your sink works fine and then all of a sudden it stops, but it's been impaired for 3 years. So in this case, the cancer cell has been growing in the breast, maybe not for 3 years, but for some time, but it reaches a critical point where the blockage leads to, where the tumor leads to blockage that causes the breast to swell dramatically. And that can lead to a swollen breast that has reddened skin, that needs a very specific treatment, which would involve chemotherapy. It's treated with a mastectomy, and it requires radiation after mastectomy because they have a high risk of recurrence even after mastectomy. The prognosis is greatly improved with that approach. The prognosis used to be about 5 years survival, about 5% at 5 years survival, 5% survival at 5 years, but based on modern treatments, the 5-year survival is above 50%. Still not 100%, but much better than before based upon this very disciplined pattern of treatment, with always starting with aggressive chemotherapy, followed by mastectomy and lymph node surgery, followed by radiation to the chest wall area. There's a question about cryoablation. When you say the body does away with the tumor over time, do you know roughly how long? Well, I think I might have answered that question, but I'll just recap since I'm that the rate at which the disease, that the rate at which the cryoablation site heals depends upon a variety of factors, the most important of which is the volume of tissue treated. So a single ablation will probably take about 2 years to go away for the average patient, 2 years to 3 years. But if you've had multiple ablations, that might be double the time it takes, might take 4 years or longer for it to go away. It also depends upon the closest to the skin. Those that are closer to the skin are more obvious. It depends on patient age. Fatty breasts, I think, take longer to dissolve than dense breasts. And also it depends on breast size. In a small breast, it's more obvious. In a larger breast, it may hide quite easily. It may be, though, that you can have a persistent mass that doesn't go away. If that happens, it might be because there's fat necrosis, which is often hard or calcified. But even with surgery, even with lumpectomy surgery, there is a mass that forms as part of the healing process that takes often some years to go away. So, avoiding cryoablation doesn't mean you can avoid a mass completely. Surgery also has its own potential for mass formation. And on the flip side, with cryoablation, you don't lose breast volume, unlike cryoablation where there is volume removed as part of the cancer treatment. So, as with many things in life, there's a trade-off. You figure out which factors are more important to you. But I don't want anyone to walk away thinking that, in every case, the breast tissue returns to a normal field after cryoablation, because, everyone's different, every scenario is different, and we're still learning, how that manifests for the average patient over time. I did have a question about recurrence, and I'll address it both in the context of surgery and in the context of cryoablation. So, we do our best. Nothing about this is perfect, unfortunately. Imaging isn't perfect. Surgeons aren't perfect. But what we do is we look at the anatomy of the disease as best as we can determine it with mammography, ultrasound, and possibly MRI, and then plan treatments based upon that. But even in the best scenario, even if you do a lumpectomy, even if you get widely clear margins, It does not mean that there's not small areas of disease beyond the area treated remaining in the breast that can be a source of recurrence. History has taught us that that phenomenon happens. And it's for that reason that we routinely recommend radiation after lumpectomy, even with clear margins, because when we compare women that receive radiation to those that didn't, women that receive radiation have 1/3 the risk of recurrence as those that did not receive the radiation, meaning that the risk of recurrence is 3 times higher in those that receive no radiation compared to those that receive radiation. It's treating something, even though the tissue looked normal. So, cryoablation is like surgery in the way that we aim to address the tumor. We aim to account for a margin by treating a little bit more than a tumor. But just as with lumpectomy, we can't guarantee that there isn't something beyond the thing that we see that imaging just hasn't shown us. Maybe it'll show up in a year, maybe it'll be detectable in 2 years. It just isn't visible at the time. If it were visible, we try to include it with surgery or with cryoablation, but it's just not visible. Therefore, we can't really guarantee that it's addressed. So we advise patients as a result to consider taking radiation, especially in moderate to high risk situations, or to take anti-estrogen medication, because those things have been shown to reduce the risk of recurrence beyond the area that was targeted. In my experience in doing cryoablation, and as with surgery, when recurrences happen, most times they happen at the borders of the area that was treated, not in the exact same spot, but at the edge. It's because it's an area that looked normal. We didn't remove it because we thought it was fine. Even though we irradiated it, some of them were recurrent. So in some proportion of patients that will happen. Now, for patients that seek cryoablation, it's for some that seek surgery, many of them are not as open to radiation, not as open to taking anti-estrogen medication. I certainly advise them, try to do my best to advise them of the potential benefits that those things can provide, but I also respect their decision when they decide, that for them that they're not willing to do those things. Again, I respect their decision to do so. It's just important for them to understand that with any decision we make, there are potential consequences or things we have to accept. And in making a decision to avoid radiation or making a decision to avoid anti-estrogen therapy, they're also making the decision to accept potentially a higher risk of recurrence. And that's fine as long as they're doing that with their eyes wide open. Hopefully, that'll motivate them to utilize, whether it's lifestyle measures, other things to reduce their risk, or adhere more closely to screening because they have a higher risk of recurrence. Therefore, we should watch more closely to see if we can detect a recurrence. You find a way forward. But if the concern is how can I minimize my risk of recurrence? The evidence is clear that from most tumors, especially in younger women, they benefit from radiation. And for women with estrogen receptor positive tumors, they all benefit from anti-estrogen therapy in terms of producing a measurably lower risk of recurrence. We often debate, the potential for side effects of anti-estrogen therapy, which many people opt not to take because they fear the potential risks. I tell you quite honestly, for every patient that I see, for as long as I can remember, when they come in for follow-up, because unlike the radiologist, I do provide follow-up at least for some period of time for patients. I ask them, if they're taking the anti-estrogen medication, and I ask them, how are they doing? Are they having any issues with it? And I tell you, it is clearly well above 80% say they have no significant problem with it. Maybe 15 to 20%, or rather 15% say they've had some problems, they've had to make some adjustments, maybe on the dose, maybe changing the medication, but they were able to find a place where they were able to take it without having it be too disruptive to the quality of life. About 5%, no more than 5%, say it was such a problem that they had to stop. So that tells me that women who could potentially benefit from it should give it a shot, meaning that you're more likely to be in 80%. You're quite unlikely to be in the 5%. The only way you truly know is to give it a try. So I try to encourage them to start the medication, to give themselves a chance to prove that it can work for them. If it doesn't work, they can simply stop. In maybe 1 to 2 months, the symptoms that they've experienced will gradually go away and they'll be back to where they were before they started. So they would not have burnt the bridge that they can't cross again. But the potential benefits of it are so great that it's worth the risk. It's worth determining how it responds in you on an individual basis, because it's quite, an important tool to manage, not just the risk of recurrence at the tumor site, but also the risk of recurrence in the lymph nodes, and more importantly, the risk of recurrence in a distant part of the body, like the lung or liver or bone, things we can't easily cryoablate or treat with surgery or safely radiate. So I have 4 minutes left, and so I want to see in the remaining question if there's one that I should dedicate the time to. But I wanted to at least make that point about endocrine therapy and radiotherapy, because the question was about the risk of recurrence. The risk of recurrence is based on a number of things. I talked about radiology being imperfect and about imaging, about surgeons being imperfect, but my patients aren't quite perfect. Sorry to say that. We're imperfect in our decision making as well, and sometimes we make decisions that may predispose to a higher risk of recurrence. So at least as much as you can, I want you to make decisions that minimize the risk of recurrence. We can't get the risk of recurrence down to 0 for every patient, but it can certainly be a much lower number from most, especially if they were thinking about avoiding radiation or avoiding medication. You can often achieve a much lower risk of recurrence when those things are integrated into the treatment. Okay, last question now, just addressed. There's a question about lymph nodes. So there are patients that come to me with lymph node disease that seek to avoid lymph node surgery. And I think that, I certainly recommend to them that lymph node surgery, at least limited lymph node surgery, is better than no lymph node surgery. But for those that simply refuse lymph node surgery, I will offer cryoablation to some. I think cryoablation has a role to address what you can see, like the obviously abnormal node, but sometimes there are nodes that are clearly abnormal by feel once you're in surgery that don't look abnormal by ultrasound, perhaps because they're too small. So I think that if the goal of the treatment of lymph node management is to minimize the risk of lymph node recurrence, while also minimizing the potential side effects of lymph node treatment, I think a more limited surgery where we take out the grossly abnormal node and feel around for any other abnormal nodes and taking those out as well is a better treatment than simply freezing the node you see or blindly freezing nodes that are nearby and leaving the remaining nodes unassessed. Secondly, even when we, regardless of which treatment we pursue, whether it's a treatment with cryoablation of the node or treatment with surgery of the nodes, if you have lymph nodes involved and you want to minimize the burden of lymph node treatment, I think the better combination is to take out the gross nodes and irradiate the rest. Radiation works really well for microscopic nodal disease, and it has a much lower risk of lymphedema complication than surgery. So there's a way that you can kind of marry the two together, whereby you limit the extent of lymph node surgery or lymph node ablation by focusing on only the obviously disease areas, but rely upon radiation to treat the rest, because it can treat it with much greater effectiveness and not just treat the grossly abnormal nodes that you see, but also treat the nodes that are likely abnormal as well, but have not yet turned normal. They have not yet turned abnormal in their appearance. So I'll conclude the questions on that one because I think we're now out of time. It's 1:30, and I want to respect your time and as well. But I want to thank you for the opportunity to share my thoughts, and some of it was my opinion about the management of breast cancer, where we are, where we need to be, and how to make best use of the information we have now. For those of you who have questions that are unanswered, there'll be another webinar in November. So hopefully your question can wait, and we can entertain it. We can entertain it at that time. I want to thank all of you for coming out, and thank Allison for her support behind the scenes and putting on today's webinar. Stay tuned for announcements regarding the series, which is to be announced for 2022. Some things will be the same, some things will be different. We haven't figured it out yet, but we'll do our best to make it interesting. Thanks so much. Have a great day.